Sometimes there's not. It sounds really weird, but sometimes it's not a consent. If there's not a consent, and by that I mean, because you're probably thinking, well, everybody gets admitted with a consent. They do, but the consent must specifically state blood transfusion. You're absolutely right. Everybody gets admitted with a consent, but this consent must specifically state blood transfusion because it's such a controversial issue. And even though we've gotten it to a fine science where you're not likely to get HIV or hepatitis from it, it's not impossible. Plus, your patient may have some cultural issues like Jehovah's Witness and they're not feeling a blood transfusion at all. Okay, so just make sure there's a consent. For kids, you already know parents have to consent, and that's anybody under 18. Okay? All right. Now, so we have a couple of rules. The rules are nicely highlighted on the pink packet, and so you're literally going to just take your highlighter and highlight. When we do blood administration, obviously before we can do anything, we have to know that our patient is actually okay. So you've dropped your vital signs, you got the lung sounds. When we say urine output, make sure you know that the patient has to void first, or you have to empty the Foley first before we start the transfusion. Because if there's a Foley bag full of urine, you don't know if hematuria was there before the transfusion or after. So empty the Foley bag or have the patient, give you a urine specimen to get a baseline. So that's why you see that there. Kind of know the labs. What kind of labs? Well, what's the baseline H&H? The whole point of giving a blood transfusion is to bring the patient to a stable hemodynamic point in their stay at the hospital. So if they started off with a hematocrit and hemoglobin of 6 and 18, which is typical for blood transfusions, then we know that 1 unit of blood will bring the hematocrit up usually by 3%. 1 unit of blood will bring the hematocrit up by about 3%. So that's why you need a baseline. Because every unit of blood that we give, 1 unit will bring up the hematocrit by about 3%. Okay, so you are doing that baseline assessment. You already see check the orders, sign consent. Then it says check the patient's ID band. Remember that your number one first identifier, no matter what you learned in school, is the ID bracelet. Number one. That's also on your white packet. And what I want you to write on this white packet is that it is the number one identifier. So you'll see that right up there under this little key. Verify patient's ID. That ID bracelet is the number one identifier. Okay? Okay. Now, a couple of rules that you learned in school. You know that you have to make sure that 2 nurses check the blood. It has been in my career, me and a physician or a resident, because when all shit hits the fan, we just need a warm body with a license. Okay? It can be an LPN, it can be an RN, it can be an MD. Just have a license and we can check this blood. We don't warm blood anymore. We used to. I used to have to get the blood warmer and have all this hot water in there and all this other kind of crazy stuff. We don't do that anymore. The type and screen that you see there, you'll see on the pink sheet it takes 72 hours. I mean, not takes, oh, God forbid. It does not take 72 hours. It's good for 72 hours on your pink sheet. It's literally good for 72 hours. The type and cross is only good for 2 days. Type and crosses take longer. So a good nurse anticipates when she's going to need one. That's important. That's called critical thinking. So a good nurse literally anticipates when she's going to need a type and cross because it takes so long. It takes so long to do. You don't have that kind of time. when all hell breaks loose, you don't have hours, you just have seconds to get your life together, right? So let's give you examples, right? We know that patients that have a placenta previa, hooking you up with maternity, a patient with a placenta previa is going to get a type and cross on admission. A patient with end-stage cirrhosis needs a type and cross on admission. A GI bleed needs a type and cross on admission. These are bleeding situations. They're insane. I mean, you know that you're going to be giving blood, you know, for crying out loud. Let's get a jump on it. So type and cross. All right. A lot of GI emergencies are type and crosses. Okay, now, I teach my new nurse, yes, baby.
Do you need an order for a type and cross?
You need an order for everything.
Okay.
But in the real world, just keeping it real, if I know a patient's coming in with a placenta previa and her OB called me to say that, I already have all the paperwork done for type and cross. And when whoever, Joe Blow resident, when she arrives, Joe Blow resident puts it in the computer, I'm way ahead of the ballgame. I've already pulled my tubes. I've already got them ready. I know exactly what to do and how to do it for a type and cross. It's really like you're preempting the strike. You know what to do. So it's a time saver. It really is. All your paperwork is marked already. You're just waiting on a sticker. You're just waiting on a sticker for the blood tube. You're waiting on a sticker for that rec you pulled already. Everything's filled out, ready. Yeah. Okay, so good question. Okay, now 30 minutes. We have on our pink sheet 30 minutes. Here's how this works, everybody. This is your highest priority. Blood transfusions is your highest priority. Generally speaking, it's who you see first and what you do first. So I teach new nurses when they are on the floor and the doctor has written for 2 packed red blood cells, 2 units of packed red blood cells. I teach them, you're not going to lunch. You're not going to get a break. Your priority is to watch for the blood to arrive, and as soon as it arrives, give it. You don't, what did the young lady do that got fired the other day at one of the neighboring hospitals? She put it in the fridge till she got back from lunch. Bless her little heart. This shit really does happen in real life. Major hospital in the city. She put it in the fridge till she got back from her lunch. You're not about to do that? Because here's my deal. I'm a provider. If I ordered blood, it was life and death. I don't just order blood like Kool-Aid. If I ordered blood on a patient, it was seriously needed. So I need you to give it as soon as possible because it was a last resort anyway. So you guys know, within 30 minutes of it hitting the floor, bam. Now be careful, because sometimes they send 2 units up at a time. What are you going to do with that other unit? You got to send it back down. You got to send it back down, because common sense tells you you're not going to give it within 30 minutes. So you can't do it. And they do that. So you're going to send that unit back down. And remember that the typical unit of blood on average takes about 2 hours to give. Typical unit of blood on average takes about 2 hours to give. If you look at the pink packet, you only have 4 hours total to give it. So I want you to highlight that. Your 4 hours is all you have on your pink packet to make sure this infusion's complete. So here's our deal. You hung the blood at 8 o'clock. It's 12 o'clock. You only have 30 cc's left. So take it down. Why? What could develop? Infection, yep, you bet. You can't even defend that one. Okay, so just some things you know is going to be a big deal. If you look at the pink sheet, normal saline is the only thing we hang with blood. You do have to change the tubing. The tubing usually, comes with it. You have to change the tubing with every unit. You do need a filter, and I want you to look at the gauge needles that I wrote there. You see it says Y tubing, must have a filter, and then it says something about 16 or 18 gauge. 18 is the standard of care, 20 if you're elderly. Never, ever, ever more than a 20. And the bigger the number, the smaller the needle, right, guys? Okay? Now, I don't know what the heck is going on out here, but every time I have a big old class, not this little tiny group, but every time I have a big old class, I ask the whole class, how many of you, I ask them to raise their hand, how many of you were in clinicals, the nurse gave blood, as soon as she hung it, she asked you to watch it and left. Did that happen to anybody here? I know. It happens every time. You will never do that. You will never, ever, ever hang blood and walk out the room. You will stay in that room like I have for 30 years. How long does it say right on your pink sheet? But believe it or not, people do it all the time. They walk out. They're like, okay, I've hung the blood. Hey, girl. I've hung the blood. Now, you watch her. I'm going to go run and get whatever. That ain't going to be you. I will find you. I will hunt you down. And I will shake you in your kidney and punch you in your throat and yank out your hair one by one of your eyelashes and your eyebrows. Because you can't do that, right? Y'all get that? Did I make myself clear? I hope so. Because what happens in the first 30 minutes? Everything? Oh my God. You know what the nursing student said happened to her when her nurse left? She said, Shelly, it was like clockwork. As soon as she said, I'll be back, and I'm sitting there with the patient moved their arm. It wasn't anchored correctly. Blood everywhere. Squirting all around the room. You can only imagine. Yeah. IV came out. It wasn't anchored correctly. So what was she going to do? She's a nursing student freaking out. You can imagine yourself as a student seeing that. Like, oh my God, what do I do? And then you look kind of klutzy with the patient. Like, because they're looking at you like, hey, what you sitting there for? Get up. Help me out here. Come on now. I got blood everywhere. Okay? Okay, so don't do that, baby. Now, here's another thing you don't do. Again, it's in capital letters. You do not delegate anything that first 30 minutes. You do not delegate anything that first 30 minutes. Okay? So you're doing the doggone thing. Y'all see how serious this is. Now, blood bank, the bag itself goes back to the blood bank. You see what I wrote. There's lots of types of blood. I want to go over some of the types of blood, just to kind of give you an idea of when you use, what you use, how you use, if you use. The most common type of blood we're ever going to use is the PRBC, packed red blood cells. That information, if I were you, I would write it on here. Because when it comes to PRBCs, I want you to write it on here because it'll give you a little bit more space. It's not a lot, but it is a good handout to write that on there. So why don't you put PRBCs and put roughly, this is 250 cc's of volume, because you got to keep strict I's and O's. So again, you're writing it on the front of this white packet, and you've got PRBCs equals about 250 cc's of fluid. This is what you're going to hang almost on everybody. We do it for our maternity patients, our trauma patients, surgical patients, I'm going to say those three again because they're important. OB patients, surgery patients, trauma patients. Fresh frozen plasma, FFP, you're going to put on that white sheet. Remember, it's yellow. We use it with burn patients. We use it for DIC, liver disease. Platelets, those are yellow. You had to remember with platelets to agitate them. What does that mean?
Right.
Don't ever say shake on this test, right? You just go like this, you know? You don't do this, do you guys? Because here, if you do this, you're going to break each cell. So you just agitate. Okay? Agitate the platelets before we hang them. Cryoprecipitate. Cryoprecipitate. You do not need a type and screen for cryoprecipitate. Okay? Okay. You got it going on.